Hello, welcome to the Satellite Symposium under the title of Optimized Treatment for Complex PCI and Hypertension. This session is supported by Medtronic Korea. This is a 6-minute session. We prepare 10 minutes for speeches, followed by a discussion. Let me introduce the panel. Two panels for this session, Dr. Jang-Whan from Chang-Wook National University Hospital, Korea, and Dr. Tzung-Dau Wang from National Taiwan University Hospital, Taiwan. Okay, let me introduce the first speaker, Dr. Jeehoon Kang from Seoul National University Hospital, Korea. His title of speech is Onyx 1, Data Subset Analysis Relevance to your clinical practice. Dr. Kang, please.
Thank you for the introduction, Mr. Chairman. My name is Jeehoon Kang, and I'm from Seoul National University, and it's a great honor to speak at the TCTAP 2021. The topic of my speech will be the Onyx 1 RCT, deep dive into the recent data subset analysis and the relevance to my clinical practice. I have nothing to disclose. This is the context. I will talk about the Onyx 1 RCT summary, and then the subgroup analysis, specifically the ACS subgroup and the AFib subgroup, and then the clinical implications on my routine practice. Now, we all are very familiar with the concept of high bleeding risk characteristics, and it is known that up to 40% of patients that undergo PCI have a HBR characteristics. Among these patient populations, current guidelines recommend the usage of DAPT for 3 to 6 months, or even as short as 1 month. And previously, the Leaders Flee trial compared the biofreedom stent with the BMS in HBR patients and performed the safety and efficacy of the biofreedom stent. However, the biofreedom stent is not a stent that we really currently use in real-world practice. So there was no study that had compared the DES with the biofreedom stent using a 1-month DAPT strategy. So this was the slight overview and design of the Onyx 1 stent. As you can see, the high bleeding risk patients were enrolled and were randomized to a Onyx arm and the biofreedom arm. And 2,000 patients were enrolled in a very short period, which means that this patient population was a very homogeneous population with no difference in the treatment strategy using PCI. We can see that including Korea, various countries and various patients were included in the study. The HBR inclusion criteria is slightly different from the ARC definition, but at least in this study, the patients that included any of these 12 factors were included in the HBR criteria. And we can see that the elderly population was the most. The patients who were under oral anticoagulant were about 40%. And from this criteria, we can see that the patient populations were, the patient had about 1.6 criteria per patient. However, the age over than 75 years old actually is only a minor criteria according to the ARC definition, which means that this patient population might be slightly a lower bleeding risk population compared to the current HBR criteria that we are using right now. So regarding the outcome, the cardiac death MI and outcomes were very similar between the biofreedom and the Onyx stent. And we can see that there was a slight elevation of clinical events in the early period in the Onyx arm. I will talk about this later in my speech. So regarding the summary of the Onyx 1 trial, we could see that this was the first trial that compared DES versus a DCS, investigating a 1-month DAPT. And this trial could prove the safety of the Onyx 1, the Onyx stent in patients using a 1-month DAPT strategy. Regarding the secondary outcomes, we can see that there was a slight higher instance of periprocedural MI in the Onyx arm, while the spontaneous MI was higher in the biofreedom arm. This was a point that was further analysis, and we could see that there was more stent thrombosis in the DCS, while the bleeding rates were very similar between the two groups. So there was a lot of issues raised about the higher periprocedural MI in the Onyx group, while the spontaneous MI was lower in the Onyx group. So this was a further analysis that was performed on the periprocedural MI. And interestingly, the periprocedural MI did not have any clinical implication in the 1-year outcomes compared where the spontaneous MI was a very hazardous incident in the 1-year outcomes. So based on this analysis, we could see that the periprocedural MI was higher in the Onyx group. However, this may be due to the difference in ascertainment. And also only the spontaneous MI is a clinical important MI that we should focus on. Now I will go over to the subgroup analysis in ACS patients. Out of the 2,000 patients, we could see that there were 500 and about 500 patients each from each group. And there was further analysis on this patient population because this patient population is those patients with a higher thrombotic risk. We could see that even in ACS patients, the risk was very similar for the biofreedom and the Onyx arm. However, we could see that the divergence in MI and spontaneous MI was larger compared to the original analysis, saying that the Onyx might be more safe in thrombogenic conditions such as ACS. Also, we could see that the events, although they were statistically insignificant, we could see that some of the outcomes were significantly higher in the biofreedom arm, which could again confirm the safety of the Onyx stent. So this is the subgroup analysis of the AFib population, which is a very interesting finding. So this, the AFib subgroup analysis was not only based on the Onyx 1 RCT, but also the Onyx Clear study, which was a retrospective cohort that included patients with high bleeding risk who were treated with the Onyx stent. And at a final analysis, there were 500 patients with AFib and about 1,000 patients without AFib. This is the HBR criteria of the AFib and non-AFib patients. And interesting, we could see that the AFib patients had a higher percentage of oral anticoagulants, which is very obvious. However, other factors were less in the AFib population. So according to this finding, we could see that the AFib population had a higher percentage of prescribed antithrombotic medications, but the clinical risk factors might have been lower in the AFib population, which means that just the clinical factors may be less severe in the AFib population. Even in the baseline clinical characteristics, we could see that the AFib population had a less percentage of diabetes. Hypertension and hyperlipidemia was slightly higher in the AFib population, and previous PCI was also slightly higher. However, there were less B2C lesions in the AFib population, and the total stent length was shorter in the AFib population, which again confirms that the AFib population might have a slightly lower clinical risk compared to the non-AFib population, whereas the AFib population is a high bleeding risk population because of the medications that we prescribe to the AFib population. Regarding the clinical outcomes, we can see that there was no difference in the ischemic outcomes, while the BARC 2 to 5 bleeding outcomes was more higher in the AFib population, which may be again associated with the prescribed oral anticoagulants that we prescribe to the AFib population. Even in the Kaplan-Meier estimates, we can see that there was no difference in the cardiac death MI. However, there was a significant increase in the AFib population in BARC 2 to 5 bleeding events. So as we can see, the AFib patients have various clinical factors. However, we're prescribed with more oral anticoagulants, and this was a factor that made AFib populations the high bleeding risk populations. In 1-year outcomes of ischemic outcomes, there was no difference in the AFib and non-AFib populations. However, the bleeding outcomes were more higher in the AFib populations, probably associated with the oral anticoagulants. Now, I will talk about the clinical implications in my practice. We all know that the ischemic outcomes recurrence after stenting has dropped considerably, probably due to the improvement of the stenting technology, improvement in the adjunctive medical therapy that we all do in current practice. However, ironically, the incidence of major bleeding has increased, and this may be because of the use of more potent P2Y12 inhibitors, and also the more vulnerable patient population that we treat compared to the past PCI population. Also, the DAPT-related or NOAC-related bleeding is one of a very important clinical complication that we should pay attention after stent implantation. As we all know, the ARC consensus was showed that there is a new nice criteria of high bleeding risk patients. And also in East Asians that we are treating in East Asia, it is well known that these patient populations have a higher bleeding risk, and we should pay more attention to the bleeding risk in these patients. Even in the host RPA's trial, which confirmed the safety of de-escalation therapy, we could see that the major determinant of the beneficial event of de-escalation therapy was not ischemic outcomes, but it was a reduce in bleeding outcomes. So controlling the bleeding events is the most important factor in the current PCI population. So then how many patients are by definition HBR patients? This is a preliminary data of the NIHS system in Korea. So we analyzed 430,000 patients who received PCI. We could find 60,000 patients who met the HBR criteria by the ARC definition. And we can see that the HBR population had a higher event of death, MI, and even ischemic stroke and hospitalization for major bleeding during a median duration of 5 years. So the high bleeding risk patients are not only high bleeding risk, but they also may be high ischemic risk patients also. So this is the conclusion and summary of my speech. The Onyx one was the trial that proved the efficacy and safety of the Onyx DS in high bleeding risk patients. The clinical implication of periprocessor MI needs further investigation, and the efficacy and safety of the Onyx was persistent in ACS patients. AFib patients had a higher bleeding risk, but this may be because of the medication that we prescribe to AFib patients. Also, many patients that we meet in the clinic are HBR patients, and bleeding is an important factor that we should control. And it is well known now that HBR patients have a higher risk of both ischemic and bleeding adverse outcomes. Thank you for your attention.
Thank you, Dr. Jeehoon Kang, for your nice, really succinct, essential data from your excellent lecture, Onyx 1. We are going to ask you several questions in the last Q&A session. We are going to move on to the second speaker, Dr. Wonjae Lee, Seoul National University Bundang Hospital, Korea. Title of his lecture is Learn from Practice, Optimal PCI Treatment for HBR Patients. Dr. Lee, please.
Thank you, Chairman. My name is Wonjae Lee from Seoul National University Bundang Hospital. It is my honor to speak here today, especially in the presence of my mentor, Professor Hyo-Soo Kim. So I'm going to talk about short depth strategy for high bleeding risk and also depth strategy for high ischemic risk. And I'm going to share some of my cases on this kind of patient population. So now we are seeing more and more patients with a higher risk of bleeding. People are older, people are CKD, they are on long-term use NSAIDs, also they have AFib with DOAC. And according to ARC definition, high bleeding risk population make about 40% of PCI that we do today. Why is this so important? Because we know that mortality after occurrence of bleeding is very high. If you look at this graph at 1 year, the all-cause mortality rate is almost about 20%. And we know that shorter depth might mitigate this event. So there has been a lot of many short depth trials, and we are at the 2021 right here. And now we have already seen a lot of good results for a lot of trials, including Onyx 1, which was just presented, and also very landmark 2 landmark study recently have been published with the newer P2Y12 inhibitors at TICO and post-Post-Tech ACS trial. So let's look at some of the clinical trial results. So STOP depth trial, which was to evaluate safety of 3 months depth. So performance goal was 6.6, but in turn, the result of 2.8, which was very, very low. And also there was no definite or probable stent thrombosis at 1 year. Smart Choice, which was done in Korea using some of the stent that we use today. And it also looked at safety of 3 months depth strategy. And you can see that whether they use depth or P2Y12 single, there was no difference in composite outcome. And as expected, there was much more bleeding event in depth group. Stop Depth 2 trial, which was done in Japan, which looked at safety of 1 month depth strategy. And it was all-comer trial, and it included about 8% of ACS patients. And if you look at the graph, 1 month or 12 months depth, composite of MACE and also hemorrhage stroke, there was no difference. As you can see, there's much more bleeding with a 12-month depth strategy. So, given this result, it seems like shorter depth will really benefit patient. But however, how about ACS patient? How about patient with heavy calcification, left main disease, bifurcation? I think these patients still might need prolonged depth, or they might need more potent antiplatelet agent. So this was a trial that showed some concern of a shorter depth in ACS patients. A SMART date trial looked at safety of 6-month depth in ACS. So MACCC was not different between 6-month depth or 12-month depth. However, if you look at just MI, and especially if you look at the landmark analysis, right after 6 months where a single depth was discontinued, you can see that there is a continuing increase of event in MI in a single depth strategy, which gives us concern that in ACS, maybe still short depth might be a concern. This is a design of ideal left main, which evaluated left main disease for 4 months depth strategy. So basically, this trial compared synergy with 4 months depth and giants with 12 months depth. Since there was a difference, and it was a little bit hard to interpret the result, but there definitely showed our some of concern. So the red line here is a synergy plus 4 months depth. You can see that after 1 year, you see depth 4 events of deafness from thrombosis, which raises concern that in left main disease, still maybe shorter depth might be dangerous. This is meta-analysis of looking at duration of depth after complex PCI. It was a pooled analysis for from the 6 trials. So as expected, if you see the cardiac death, MI and stent thrombosis, definitely with complex PCI, there is much more MACE as you expected. However, there's no different bleeding. What stands out is that if you look at the bifurcation with the 2 stents, it had highest risk among other complex PCI components. And if you look at stent thrombosis, it's about 4 times higher if patient had a bifurcation with 2 stents. So if patient has no high-risk procedure characteristics, whether patient used 12 months more or 3 to 6, it doesn't really matter. However, if patient have 1 or 2 high-risk procedure characteristics or 3 or more, patient will favor more the longer depth duration. And if they do use shorter depth, they're going to have some hazardous effect that we do not want to have. So it's really important that ischemic benefit on long-term depth according to the degree of PCI complexity. I think Dr. Kang already stressed about this part, but I just want to say once more. It's a subgroup analysis for Stop Depth 2 trial HBR. It look at the CV death, MI stent thrombosis stroke. It really doesn't matter whether patients on 1 month depth or 12 month depth. If they are HBR patient, they're going to have a higher cardiovascular event rate. So this really puts in a very hard condition because we want to control high bleeding risk, but this patient have also ischemic risk. But I think the following 2 trials give us some answer to mitigate these kind of problems. So this is TICO trial. I think you all are aware of this study. This is ischemic risk result. If you look at the ticagrelor monotherapy after 3 months depth, statistically, it wasn't significant, but you can see that it numerically improves MACCE compared to depth if you only use 3 months. And this host redeployed to ACS, which evaluated prosecutor-based de-escalation dual antiplatelet strategy. And also, if you look at efficacy outcome, there is a trend of lower incidence with de-escalation. And of course, if you look at safety outcome, de-escalation really benefit for the patient. So I'm going to share some about cases with HBR patient. It was 87 male. He suddenly collapsed at ROC, and at ER, he had an inferior MI. He was old and had a liver cirrhosis, and he was a chronic alcoholic. There was near total occlusion mid RCA, so simple POPA, and also Onyx 3.0 implanted, and financial looks pretty good. However, 2 days later, patient presented in melena with hypertension. Gastroscopy was done. There was a multiple bleeding. And duodenal ulcer was found, so we had to do hemoclipping. Bleeding seemed to control, so I discharged patient aspirin and clopidogrel with PPI. However, 4 months later, patient visited ER again for melena, and yes, patient was still on aspirin and clopidogrel. Gastroscopy showed only scar, but patient had recurrent event of melena, and we had to transfer this patient to other hospital for further care. But unfortunately, I could never see him at my clinic again. Second case is 82 years male, recent development chest pain, and he was waiting for the admission, but patient just collapsed, came to ER. Patient had a MDS, myotic syndrome, which means he had anemia, also thrombocytopenia, which puts him in a high bleeding risk. So we decided that we're going to just touch really critical lesions. So patient had some lesion, tight stenosis in RCA, but we just to leave it. And also patient pretty long lesion at proximal LAD and some lesion at the tight lesion at ramus intermedius, but we decided to just touch the corporate lesion. So we put only 2.5 at distal LAD and 2.75 at proximal LAD. But still patient hypertensive, we had to put another stent in ramus with the Onyx 2.5. So this is final angio. We still have some remnant disease here, but since we wanted to minimize metal burden, we decided to just leave it like that. So since this patient had a very high bleeding risk, DAPT was maintained for just 1 month, and we changed to clopidogrel single strategy. However, thrombocytopenia keep progress, so our hematologist decided to put patient on aspirin QOD. 1 year later, this is a follow-up angio. There's some disease here, but and some ISR here, but pretty much looks good here in LAD and also ramus. And patient's really doing well right now. This is my case to share. 77-year male. He has a chest pain for 1 or 2 years and TMT positive. So patient admitted for coronary angio. Patient had proximal AFib, which puts him in with a DOAC. So again, this is high HBR patient. We decided to minimize the procedure and keep it simple. Patient had pretty diffuse tight stenosis in proximal to distal LAD. And RCA, there's some disease, but didn't seem too critical. So we decided to just do treat the LAD here. POVA was done. Only 2.5 was implemented. Adjunctive balloon after rewiring, and final looks pretty good. We did sacrifice some diagonal vessel, but we decided to leave it just like that. So we maintained depth plethoric for 1 month and enrolled the Onyx 1 trial. And after 1 month, we dropped aspirin and maintained DOAC and clopidogrel. And after 1 year, we decided to just give DOAC to mitigate his high bleeding risk. So this was a 1-year follow-up angio. Some progression in native vessel here, right here, but stented reason looks similar to the final result before, and RCA did not have significant changes. So this is my take-home message. I think we should definitely consider a shorter depth strategy for patients with high bleeding risk. And if possible, we should try our best to simplify PCI procedure and minimize metal burden for patients with HBR. And I personally, shorter depth duration or de-escalation strategy with newer P2Y12 inhibitors may be a solution to mitigate high ischemic risk, patients with high ischemic risk and HBR. Thank you for listening.
Thank you very much for a wonderful, beautiful lecture, Dr. Wonjae. We are going to discuss in the later regarding your subject. The third speaker is Dr. Chang-Wook from Gaemyeong University Dongsan Medical Center, Korea. His lecture title is Step-by-Step Approach for Complex Bifurcation Treatment. Professor Na, please.
Thank you, Chairman. I'm Chang-Nam from Gaming University, Dongsan Hospital. It's my great honor to have a chance to share my experience with all of you, especially respectable Chair, Dr. Hyo-Soo Kim. Today's my talk is about the step-by-step approach for complex bifurcation treatment with a representative case. This is my disclosure. 66-year-old gentleman was admitted with angina, and then this is in angiogram. We can detect RAD and diagonal through bifurcation region. Diagonal artery is really big size, and you easily detect it's a true bifurcation one-on-one region, but the diagonal artery branch is relatively big territory, but very short segment of disease. So in this kind of true bifurcation region, you are wonder whether you approach initial two-stent strategy or provisional strategy. According to the previous European and Korean data, European, Nordic, Baltic, and BBC1 trial, randomized trial showed a two-stent strategy was worse than one-stent strategy. And according to Korean RAJI registry data, also in left main bifurcation region, two-stent strategy was worse than one-stent strategy. But in another study showed that if you lose a side branch, cardiac death and MR rate can be increased. So if you can save the side branch, big side branch, you can start with a provisional strategy. But if you have a high chance of a side branch loss, it's better to start with the two-stent strategy. So for my indication for initial two-stent strategy, first one is the most important thing, large myocardial territory of side branch more than 10%. And second thing is a long segment of side branch disease more than 10 milli. And third one is high risk of side branch loss. And fourth, difficulty of side branch rewiring. If the number of risk factor is lesser than 2, I'd like to usually start with a provisional strategy. If the number of risk is more than 3, I start with a two-stent strategy initially. Within them, depends on the case. How about in this case? This case, definitely diagonal branch territory is more than 10% of myocardium. And how about the second one, lesion length? A very short segment, so negative. How about the risk of side branch loss? By angiography, it's true bifurcation region, so I think it's a high risk. But how about fourth, the difficulty of side branch rewiring? From the RAD to diagonal is relatively straight, so it is not so difficult to rewire. So the number of risk is 2. So in this case, I'd like to start with the provisional approach. But if you have still doubt about this kind of true bifurcation can be very high risk to provisional approach, then you can guide with IVUS. After RAD ballooning, I tried IVUS examination from diagonal. So you can easily detect that there was most of the disease located in the proximal part of the main vessel, not the diagonal ostium. And I also performed IVUS RAD, and then distal reference segment diameter was 3.5 and proximal was 4.0. And as I already mentioned, that most of the plaque located in the main vessel proximal part, and the diagonal ostium was relatively spared. So in this case, it looks like angiographically true bifurcation as a very complex bifurcation, but in the IVUS relatively spared the diagonal ostium, just the size discrepancy of main vessel and then wide angle, so we can approach with the provisional. So I decided simple cross of stenting, but I would like to follow stent size as a distal reference, because if you select a large size more than distal reference segment, there is a higher chance of proximal plaque displacement that can induce the side branch loss. And then we have to adjust the proximal part with POT technique. About POT technique, not only initial gain of minimal lumen area, but also we can increase blood flow. And when you follow after POT, compared to without POT, the POT group has a lesser event rate during long-term follow-up data. So POT will be very helpful to the bifurcation PCI. So in this case, I do the simple crossover stenting. and do pod with ball balloon. And after pod, you can easily detect the different size of proximal pod compared to upper side and lower side. Definitely lower side has increased the lumen. And next step is after simple cross stenting, there is some compromise of diagonal ostium. As already we know that angiography initially it was a tight stenosis. So we have to decide whether we have to open the side branch or not. According to previous study, routine kissing according to Korean randomized or European randomized study and large Korean registry and the European registry data showed that routine kissing after simple crossover stenting will not make a better outcome. However, according to our clinical experience about the jailed circumflex FFR measurement, if jailed compromised circumflex have a low FFR value, their outcome was very poor if we just medical therapy. So just medical therapy for large ischemic side branch will make worse outcome. So we have to decide whether this side branch should treat or not by the physiologic evaluation. So I decided to perform the FFR guidance for jailed diagonal branch. And as we can expect, the diagonal territory was a big, really big territory. So FFR was 0.62. So we have to open the diagonal branch according to our previous clinical trial. So I decided kissing and repot. But in terms of kissing balloon technique, previously we do the long overlapping kissing balloon, but recent rain registry show us that short overlapping will be better because it will not make a main vessel proximal part deformity. So I like to follow the short overlapping kissing balloon into this bifurcation region, and we perform diagonal balloon and RAD proximal balloon and then short overlapping and repot. But during the repot, we have to retract of repot balloon because we do not want to touch again about the carina area. This is the final result. According to this angiogram, it looks still some jailing of a diagonal branch, but the flow is quite acceptable, and we want to find out whether the result is good or not by imaging and physiology. This is an IBIS examination from diagonal and RAD, and then you can easily detect the diagonal part, no dissection, and the ostium was wide opening, and FFR value was 0.88. So it's quite acceptable by IBIS and FFR. And also we performed the IBIS from the RAD, and then minimal stent area was located in this part of main vessel, and the minimal stent area was more than 7, so it's quite acceptable. So angiographically and physiologically quite acceptable result. So this kind of a complex bifurcation region through 111 region and short segment of diagonal branch, it can be approached with provisional by IBIS support. And we decided simple crossover with pod and jailed side branch. Decision was performed by FFR guidance. And we do the short overlap kissing and repot, and then optimization was confirmed by IBIS. So ladies and gentlemen, most of our bifurcation can approach with a provisional strategy because it's a standard. And it's a simple and high rate of success and a low rate of complication. And IBIS and FFR guidance for this strategy is very helpful. And also, after all procedure, you have to confirm by optimization with IBIS and FFR, and always ready to cross over to complex strategy because bifurcation PCI is a very complex procedure. Thank you very much for your kind attention.
Great, thanks, Dr. Nam, for your wonderful lecture and wonderful technique. Then we are going to move on to the last speaker, Dr. Tzung-Dau Wang, National Taiwan University Hospital. The title of this lecture is Renal Innovation Clinical Update, OFF-MED and GSR Subgroups. Dr. Wang, please.
Thank you, Professor Kim, and also the TCTAP organizer to inviting me to give a talk on the current status of renal denervation. And in the following 10 minutes, I will introduce you some clinical updates, mainly including the off-med pivotal and the real-world GSR subgroup data. I have nothing to disclose. And hypertension is actually a worldwide pandemic. the prevalence is about 30% worldwide in adult population. And the control rate is actually far below 30% worldwide. And the main reason is non-adherence. I mean, the non-adherence issue is heavily underestimated, but the real prevalence is about 30 to 50% non-adherence rate. And also very important is it's a dynamic. So I will say that to forget is human nature. So probably all hypertensive patients once more or less got some non-adherence problems. So for such a chronic disease, we do need a long-term strategy if that can provide a sustained blood pressure reduction, and a device therapy by using the renal denervation strategy is a very reasonable option. And with regard to the renal denervation, I mean, the Simplicity system is the most widely studied system. And up to now, the spiral hypertension off-med trial being published, and on-med trial, and the off-med pivotal trial being published last year is up to now the largest trial in patients with hypertension, but without any antihypertensive medication. And there are some studies that are going on, including a distal study to evaluate a relatively concise strategy for renal denervation, also in the patient with atrial fibrillation and hypertension, to test whether the renal denervation can provide good results. And I will introduce you the study design of the hypertension off-med pivotal trial, because that been published last year, including 331 patients, is up to now the largest trial to demonstrate the efficacy and the safety of renal denervation. So in the pivotal trial, the off-med trial, it includes patients with a combined hypertension. The definition is office blood pressure above 150 and 90. And also the ambulatory blood pressure should be greater than 140, but there is no limitation for diastolic ambulatory blood pressure. And no medication, so the patient is was either drug naive or discontinuation of all medications, or antihypertensive medication. The patient be randomized into 1-to-1 to sham group or renal denervation group. The primary efficacy and the safety endpoint being evaluated is 3 months after the renal denervation, because, according to the current guideline, it's reasonable to, without any medication and for only 3 months, but after 3 months, by the current standard practice, we should start medication if the blood pressure is not under control. And there's a escape criteria for patient if it's greater than 180. So the physician can make, according to their discretion, the patient should be treated under the medication within the 3 months follow-up period. And the clinical results is that the office blood pressure in the renal denervation group reduced about 9.2 millimeter mercury in systolic and office blood pressure. There's a clinically significant and a statistically significant difference in office blood pressure, about 6.6, and also the 24-hour systolic blood pressure of 4.7 millimeter mercury reduction in the renal denervation group. So the magnitude of the blood pressure reduction, I think, office versus 24-hour ambulatory is very reasonable. It's about 0.5-50% or 60% of blood pressure reduction. Office versus ambulatory. And and I also want to emphasize here, because it's only observed 3 months after the renal denervation, but according to the previous experience based on the off-med and on-med, the 6 months blood pressure reduction will be almost double. So the blood pressure reduction following renal denervation will become increased within the first year after renal denervation. And it also provides 24-hour sustained blood pressure reduction. So that's called the always on effect. So it's in contrast to pharmacological therapy, because the drug have its half-life. But the device therapy, we can provide a sustained 24-hour reduction. So it's especially useful for a patient with nighttime hypertension. So before the publication of the pivotal trial, Taiwan Hypertension Society, we issued a consensus about renal denervation. We emphasize that because according to the evidence we accumulated, it seems that renal denervation is effective in all hypertensive patients, not only for resistant hypertension patients. So we summarize all the inclusion criteria about the blood pressure levels, including not only the office blood pressure, but we emphasize the importance of 24-hour blood pressure. And also we emphasize that we should not reserve the renal innovation to patients with only resistant hypertension, but all kinds of hypertensive patients could be treated by this strategy. So that's our consensus for your reference. And following the pivotal trial, that's a clinical trial, we then look at the real-world global simplicity registry data. There are over 4,000 patients being included throughout all this spiral program, and more than 2,000 patients being included in the global simplicity registry. And as I show here, so there's the first generation fast caster or the second generation spiral caster. More than 500 patients being treated by the spiral caster also be included in a global simplicity registry. There are three major findings. The first is the office blood pressure reduction achieved in the real world remains sustained over 3 years follow-up. And also the magnitude of blood pressure reduction, the office blood pressure, as you can see, compared to the pivotal, is quite similar because, as I said, the blood pressure reduction will become progressively increased from 3 months to 6 months. And we observe a 9 millimeter mercury reduction in office systolic blood pressure, but in the 6 months, 13 millimeter mercury reduction is quite similar to what observed in the Onyx trial, and also in 3 years is 16, and about half 9 millimeter mercury reduction in ambulatory blood pressure being achieved in the global simplicity registry. So the real world evidence is quite similar to the clinical trial evidence. The blood pressure reduction magnitude are comparable and remain sustained over 3 years follow-up. And also the second very interesting finding is that the blood pressure reduction achieved by renal denervation, the main determining factor is baseline blood pressure and other characteristics like sympathetic overactivity or some other determinants of blood pressure like vascular stiffness did not influence the magnitude of blood pressure reduction achieved by renal denervation. As shown here, for elderly patients, also renal denervation can achieve sustained and significant reduction. And I have to emphasize here because it's for the ambulatory blood pressure data. It's for the ambulatory blood pressure data. It's not for office. So you can see the 10, 8.7, and 10 in diabetic. And also in other conditions like atrial fibrillation or chronic kidney disease also achieve similar reduction. So clinically, we may consider for patients with a higher sympathetic tone may have a better response, but actually, according to the real world GSR data, the blood pressure reduction is consistent across all different subgroups. So finally, at baseline, as you can see here in the real world data, 13% of them under the blood pressure targets I define it here as below 140. But after 3 years, threefold increase in the proportion of patients being under control. So reach 30 to 40%, that range. And you may wonder why the medication reduction is a little bit smaller, only 0.2 tablets being reduced. That I think I can simply explain here is because the baseline blood pressure is quite high, like maybe 150 or 160. So if you can reduce the blood pressure by maybe 25 and the systolic blood pressure achieved maybe it's around 135, in that situation, you may not reduce the antihypertensive drug. So, in summary, that the renal denervation do achieve significant blood pressure reduction, maybe around 20 to 30 millimeter mercury in systolic, but the number of medication may not be, the reduction of number of medication may not be that prominent because the baseline blood pressure is quite high. So in summary, there are two key takeaways. So from the pivotal trial and also the Onyx trial, in the clinical trial, it demonstrated the renal denervation do achieve statistically significant and a clinically relevant blood pressure reduction compared to sham control. And also very important is the safety profile. There's no major safety concerns. And also it's effective in all kinds of hypertensive patient, not a drug naive patient or uncontrolled or resistant patient. And it can produce 24-hour always on blood pressure reduction. And the real-world evidence from the GSR demonstrated the sustained blood pressure reduction throughout 3 years follow-up, and in all different subgroups, including isolated systolic hypertension, also very effective in atrial fibrillation. And the GSR is currently the largest clinical follow-up program, so including more than 2,000 patients being treated by the flex caster and more than 500 patients being treated by the spiral caster. So that's the summary of my talk. Thank you for your attention.
Thank you, Dr. Wang, for your nice presentation. It's very helpful. It's good information regarding renal denervation therapy. Now we have about 13 minutes to discuss on 4 previous subjects. I'd like to invite 2 panels, Dr. Chang-Wook and Dr. Wang. So let's discuss the first subject, Onyx 1 data. Is there any comment from the Dr. Jeehoon Kang's lecture?
No. Dr. Kang, this is Dr. Bae. Thank you so much for your nice and informative lectures. I just have, 2 kind of questions. The one is Onyx 1 trial is beautiful, it's a beautiful trial, but always I see that this trial, the major adverse cardiac event during 1 year, about 2 kind of arms, about 16 and 17%. Is that not so much compared to the historic trial? The first one. And second one is the beyond 1 year, so we should select, especially in the patients with the atrial fibrillation, we should select the anti-thrombotic regimen. But usual recommendation is just a NOAC or vitamin K antagonist, but it's not so easy to do that. How do you think about that?
Thank you for your wonderful question. Regarding the first question, yes, as you just said, the instance of MACE is very high, 16, 17% within 1 year is a very unusual digit that we can see in PCI populations. However, we can see that most of the, well, not most, more than half were events that occurred within 1 month, and which included the periprocedural MI. So if we delete the periprocedural MI, the MIs that are not clinically relevant, this decreases the clinical events into 1/2 digit, which is 8 to 9%. So in the Korean or in the East Asian population, a 1 year event of 8 to 9% is still high, but in Western countries, that's the usual the usual event rate. So I think that the periprocedural MI too much ascertainment of the periprocedural MI brought this unusual digit. And regarding the second question, yes, as a interventional cardiologist, we have a very fond of using the antiplatelet agents, and we are not that very familiar for using anticoagulation for coronary artery disease. And we think that everybody think that this is a very important issue that should be investigated. The current guidelines do just recommend NOAC single, but this is not based on very scientific data. And actually, well, we are performing a large-scale RCT that is comparing low-dose NOAC plus antiplatelet regimens. So we believe that there will be a better regimen other than just using NOAC alone in coronary disease patients with AFib.
Regarding Onyx 1 RCT, I felt that is very important message. That is difference in terms of spontaneous MI between 2 stents, Onyx versus Bifurcation. Thus, when we explain the difference of spontaneous MI that is lower in Onyx, there are several suggestions. The first one is strut thickness is thinner in Onyx, about 80 micron versus 120 micron Bifurcation. The second factor is polymer. BioLink's polymer is really a biocompatible polymer, durable polymer, while there's no definite polymer on the surface Bifurcation. Thus, in our recent host-reduced polytic ACS-RCT, we witnessed there's no difference between degradable polymer DS versus durable polymer DS, but there's certain message, a little bit different digit that favors durable polymer DS. Thus, with such kind of strut design or existence or nature of polymer may affect the instance of spontaneous infarction. Okay, regarding the second topic presented by Dr. Wonjae, optimal PCI treatment for HVAC patients. Is there any comment from the panels?
So I may ask Professor Dr. Lee about the de-escalation. I would like to know the dose of the prasugrel used in that de-escalation. Is that 510 milligram or 3.75 HN dose?
I am the expert in this session, but just a simple question. So we do not have 3.75. So our de-escalation dose was 5 milligram.
Okay.
In our host-reduced ACS-RCT, we compared 5 milligrams versus 10 milligrams beyond 1 month of DAPT, including regular dose of prasugrel. Thus, beyond 1 month, we compared aspirin plus prasugrel 5 milligrams versus aspirin plus prasugrel 10 milligrams. The result is favoring aspirin plus prasugrel half dose 5 milligrams.
Okay.
It reduces bleeding instance as well as it does not increase, relatively decrease the thrombotic instance also. Thus, in terms of just a de-escalation strategy, I think we may have some confidence or comfortable feeling for the reduced dose or just a shorter DAPT. But in SMART date or ideal left main study, they compare shorter versus longer DAPT. But longer DAPT may be better in terms of instance of infarction in SMART date trial or in terms of stent thrombosis in ideal left main trial. Thus, in certain subset, we may need a longer DAPT. But such kind of study did not compare the same duration of DAPT with different dose. Thus, there are two levels of de-escalation therapy. The first level is duration, just short duration of the same medication versus longer duration of same medication. The other strategy is to reduce one potent P2Y12 inhibitor or the switch to more lenient P2Y12 inhibitor from the stronger agent. Okay, let's move on to the third topic, bifurcation. Is there any comment on the lecture by Professor Nam?
Dr. Nam, thank you so much for your wonderful lecture and your wonderful case. Actually, your case is so tough, I think, because just the diagonal branch is just only one, and so every doctor's decision is so tough. The first of all, we should think about that the first two stent strategy or some things, but everybody knows that after the 1 year or 2 years, we should think about that 4 or 5 years after the procedures. Nobody wants to make two stent complex strategies, and so I think that first of all, the invasive imaging is very important to see the plaque deposition and the plaque location about the main branch and side branch, and then enough predilation just before the main branch is stenting, and then I think that the crucial part of your lecture is the using FFR. Even though there is some kind of pinching or well dilated in the ostium of a side branch, FFR have a significant role to do or not to do provisional stenting. I think that all the part is very important to save or to exclude the strategy of two stent strategy. Thank you so much.
Yeah, thank you for a nice comment about the the imaging and physiology guidance. Actually, I totally agree with your opinion. If I just follow the NGO guidance in that kind of complex bifurcation region, maybe some high chance of a two-stance initial strategy, because it's a really a big diagonal. So I don't want to lose a diagonal branch. That's why I just wiring and then pre-dilate for RAD, then performed IVUS for the diagonal branch. Because after plaque modification, and we can detect by IVUS whether the plaque was a little moved to the diagonal ostium or not. But fortunately, in IVUS, there was no significant disease in diagonal ostium. In that case, we can approach by provisional, but as we can easily detect, the proximal part of main vessel plaque was too much. So we put the stand and then pot balloon technique. Even though it's a diagonal ostium was saved, but plaque was displaced to diagonal ostium. That's why the FFR post stand was low. And then we do the kissing, short overlapping kissing and refought. Then, even though there was a residual disease in the, angiographically in diagonal ostium, but the final FFR was quite acceptable, and also imaging was acceptable. That's why I finished the procedure. So the kind of imaging and physiology guidance will be very helpful to decide the strategy, simplify, and then device, the lesser uses of a device.
I have one question to Dr. Nam. You showed a slide demonstrating POT was better than non-POT.
Yeah.
There are several mixture of non-POT. So adequately, I'd like to request your question. POT and POT plus spinal kissing balloon versus spinal kissing balloon alone without POT. I think there is no data that favor POT alone, POT plus spinal kissing balloon versus spinal kissing balloon alone. How do you think about the superiority or efficacy among these three kinds of strategies?
Yes, that's a very important question. So still, we don't have a real randomized clinical large big data, but one the importance of a POT is not just a kind of after kissing and repot. POT is like a nomenclature, proximal optimization. Enough lumen gain of proximal part is very important. According to our jailed circumflex FFR study, when you predict, when you do the multivariate analysis, most important part of predictor was proximal main vessel stent area. Minimum lumen diameter was very important after stenting. So it means when you decide POT or kissing POT, the most important thing is a proximal optimization, not kissing or not just a combination.
Okay, just 1 minute left. So we are going to move on to the fourth subject, renal innovation. Is there any comment on the Dr. Wang's lecture?
Dr. Wang, thank you so much for your informative lecture about RDN. I just want to know just one thing. For example, in the spiral trial, after the RDN, the patient lowered the pressure in the OPSBTB about 6 millimeter mercury, and ABPM is 4 millimeter mercury in systole. And so I think that it is very comparable to just one kind of or two kind of the antihypertensive agent. And so is there any data about the cost-benefit analysis, just RDN in the naval patient versus in the drug use in relatively short, or everybody knows that there is no data about long term, but even in the short term data, even economic analysis.
Well, actually, there is no such data here, but I'd like to emphasize here, because that's only observed as 3 months. So, but that's also clinically significant. But after 6 months, I think the magnitude will probably doubled, and as you can see in the real world GSR data. So basically, I explained to my patients it's probably equal to 1.5 and 2 drugs.
Yeah.
But for quite a few mild to moderate hypertensive patients, so they may got a chance to off them all the medication in their lifetime. So I think this strategy is a very effective strategy, but maybe more effective in those with a milder to moderate hypertensive patient. But of course, for the resistant hypertension patient, we can reduce their pill burden a little bit, but let them the blood pressure down to the uncontrolled level, under control range. But for the mild to moderate hypertension, we gave them a chance. Probably they can, well, maybe off the medication. I mean, for some of them.
Okay, thank you. Thank you so much.
I was surprised at the 3 years results of Global Simplicity Registry. Overall patients, 3 years BP reduction was about 10-12 ambulatory systolic BP. That was consistent in the resistant hypertension, elderly, and diabetic subpopulation. Thus, I think it is very consistent, efficacious treatment modality. If we reduce about 10 millimeters of mercury in ambulatory systolic BP, we can delete medication, or in some patients, we cannot delete medication, but those patients' BP is significantly lowered, leading to better prognosis, less cardiovascular event. That is overall extrapolatable to the cost saving. Thus, I was very impressed at the long-term efficacy of RDN. Now, our time's up. Let me close this session. This session is sponsored by Medtronic Korea. We heard 4 excellent speeches on Onyx data or optimal PCI for HBI patients, and step-by-step approach to complex bifurcation lesion and current status of RDN. I really appreciate Dr. Bae and Dr. Wang and 4 speakers. Thank you very much. Goodbye.